Today, the power of early detection and diagnosis. I'm Erica Petrini. Access Health starts now. Each year, some 300,000 people in the United States contract Lyme disease, and according to the CDC, the number is on the rise. Lyme disease emerged from the wilds of Lyme, Connecticut in 1970. As someone who lives in Connecticut, tick awareness is always close to mind. However, recent reports indicate that incidents of Lyme disease have been reported from all 50 states. The most commonly ordered set of tests from Lyme disease are those that test for antibodies. However, there are still limitations with those current tests that can often take up the valuable time needed for prompt treatment to occur. I sat down with Dr. Raymond Datweiler, professor of microbiology, immunology, and pediatrics at New York Medical College. He is also a pioneer in the development of new diagnostic tests for the early diagnosis of Lyme disease. Doctors, thank you so much for making a house call.
Pleasure to be here.
So let's get right to it. I think that most people know that Lyme disease can be caused by a tick bite, but they don't really understand the disease itself. Can you explain Lyme disease for us?
The bacterial disease that's spread by ticks. Ticks carry the bacteria, inoculate it into your skin as they feed upon you. And it's only one species of tick that does it, but it's unfortunately a common species. It's seen here in the northeastern United States, upper Midwest, and now on the West Coast.
That was my next question, because we think of it being Connecticut, Northeast, but how prevalent is it really?
Well, it's getting more prevalent, but contrary to what people think, Lyme disease is actually a Northern Hemisphere disease. It's not just here, it's in Europe, it's in Asia, it's everywhere. And the number of cases each year have been going up.
So doctor, if someone suspects that they've been bitten by a tick or that they may have a tick-borne illness, what sort of signs and symptoms should they look for?
The classic sign of Lyme disease is a very characteristic skin lesion called erythema migrans. Erythema means red, migrans means expanding. But the hallmark is it gets bigger. Now, if you get bit by a tick, you're going to have a little area of redness just because you got bit. Erythema migrans will go from a dime or quarter size of a tick bite to an expanding lesion. That's the only sign of early Lyme disease that we have.
So I know that there are a certain amount of people who don't get the sign.
That's correct.
And so they have symptoms. What are some of the symptoms associated?
80 to 90% of individuals will get erythema migrans that have Lyme disease. It's like any other infection. You get low-grade fever. You don't kind of feel well. You feel achy. You feel out of sorts. Very nonspecific things. But if you have been bitten and then you start not feeling well, then you really should do something about it.
How do you eventually test for it then?
The primary test, or the only test that's really widely available, is a test that looks for antibodies against the bacteria that causes Lyme disease. The standard old way of doing it was to take a first test and ask, do you have any antibodies that react to the proteins of the bacteria that causes Lyme disease? And if yes, then you would do a second test and ask, are those antibodies directed against specific proteins of the bacteria? And the interpretation of these tests, which are called Western blots, is hard, very subjective, and open to a lot of misinterpretation. But also another problem is, especially in early disease, it wasn't very sensitive. So the standard test in the first month of infection, more than 50% of people with Lyme disease were negative in that test. And that gave Lyme disease testing a very bad reputation. People think, well, it's not sensitive at all. It doesn't pick it up. That's wrong, because if you, after a month, it becomes very sensitive, but you've missed a nice window of opportunity where you're able to treat people and have the best outcome. Treatment of early disease is highly successful.
I know you're here to tell us about some advancements in Lyme testing. What do we need to know?
In 2019, the FDA approved a new method, the modified two-tier system by Zeus Scientific. They took two first-tier tests, put them together in a way that allows for automation of the test, better test results, especially in early disease, and allowed for the elimination of the Western blot.
So it sounds like this new test is more accurate and allows for earlier detection.
More accuracy, quicker test results, and it's easier for everybody to do. And it's available in your standard laboratories. All you have to do is ask your physician for the new modified two-tier system test.
And that's so important. I'm so glad you're here today because I think patients need to be aware that this test does exist and they need to ask for it.
Correct.
Doctor, thank you so much for joining us today. If you'd like to learn more about Lyme disease or about the diagnostic test that we talked about today, be sure to visit zeuslyme.com. Their genes carry inherited mutations through generations of family members, bringing with them a significantly higher risk of a cancer diagnosis. Lynch syndrome is an inherited genetic mutation that is associated with an increased risk of endometrial, gastric, and ovarian cancers. It is also the #1 cause of inherited colorectal cancer. Our story begins here. Take a look.
When Jacqueline was 15, she had a lot of pain in her stomach and bleeding when she went to the bathroom. The doctor said it can't be cancer because you don't get colon cancer at this age. 4 years had gone by and many doctor visits and still no answers. Jacqueline was losing precious time.
I got a call saying, you need to come here right now.
He knew that it was cancer. His exact words were, "She has cancer and it's big."
Asking my mom, is she gonna be okay? And my mom not being able to know.
She was in such physical pain.
The genetic counselor said I'd be surprised if she didn't test positive.
For one doctor to miss it, you might understand. This was several doctors, and all of them combined missed it completely.
You talk to 10 different people and ask them about Lynch syndrome, you'd get a 0. If you went to 10 different doctors, you might find that 4 or 5 of them don't know.
And that means that over 1 million people have Lynch syndrome and 95% of those people are unaware of it.
Jacqueline died from colorectal cancer. You know, it really was a struggle for us to get the right answers. And, you know, Jacqueline went through a lot. It took 4 years for her to be properly diagnosed with cancer. And by that time, it was quite advanced. And while she was going through treatment for cancer, her oncologist suspected that she might have Lynch syndrome, actually because of her age. So that's how we found out. We talked to a genetic counselor and discussed our family history. One of the things that was tough for us is that there wasn't a lot of cancer in our family history. Really, the only person in our family that had colorectal cancer was her grandfather. She actually said to us, even though your family history doesn't show that she might have Lynch syndrome, I'd be very surprised if she didn't test positive. And in fact, she did. And then her dad was tested and he was positive too. Had we known it was in our genes, or had her doctor known there was something called Lynch syndrome, I'm sure her story would have been different.
Following the loss of their daughter, Joan and Alan Rush formed the Jacqueline Rush Foundation with the mission to save lives by increasing awareness and research of Lynch syndrome, the underlying cause of Jacqueline's cancer. Hereditary risk greatly increases the risk for cancer to develop, and in the case of those who have tested positive for Lynch syndrome, those families have dramatically increased risks for cancer versus the general population. Families with Lynch syndrome have a greater than 80% risk of developing colorectal cancer, and for women with Lynch syndrome, a more than 60% risk of developing endometrial cancer. Knowing if you have Lynch syndrome can provide your doctor with important information for implementing screening and surveillance programs. For those who have already been diagnosed with cancer, it is important that you ask your doctor to have a screening test performed of the tumor tissue as well, to determine if your cancer is associated with Lynch syndrome. It is recommended by the National Comprehensive Cancer Network that all colorectal and endometrial cancer tumors be tested for a biomarker known as MSI High. Access Health caught up with Dr. Heather Tomlinson, Director of Clinical Diagnostics at Promega. Their research and development team has pioneered MSI testing.
Understanding biomarkers within tumors can give us helpful information on how to best treat that particular tumor. Microsatellite instability high, or MSI high, is a biomarker commonly associated with Lynch syndrome. When a tumor is known to be MSI high, it's essentially missing the spell check on the DNA. That's in contrast to tumors that behave more like normal cells. Those are called microsatellite stable. If a tumor is MSI high, we can then do further testing to determine if it is Lynch associated. It's important to note that not all tumors that are MSI high are associated with Lynch syndrome, and that's why further testing is needed. When we know a tumor is MSI high, it can help guide treatment decisions, and it also enables treatment based on that biomarker specifically and not necessarily where the tumor originated in the body, possibly treating the tumor more effectively.
Once diagnosed with cancer, regardless of the site of the tumor, understanding the MSI status of your tumor can inform the best therapy option, enabling access to a new and highly effective class of immune oncology drugs.
In 2017, the FDA approved an immunotherapy drug based on specific genetic features of the tumor and not where the cancer originated in the body. Keytruda, an example of an immunotherapy drug, has been approved for all solid tumors regardless of where they originate in the body, as long as they're MSI high. This is a first ever and game changer in cancer treatment. The combination of MSI high as a biomarker and immunotherapy really acknowledges the fact that we're getting more advanced in our ability to understand cancer and treat it, and figure out how to really make a personalized approach for each individual based on what's happening in their body. I feel like much hope is on the horizon for people with Lynch syndrome. You can take advantage of both preventive strategies as well as early detection if you know you're a carrier. Right now, we have the first ever clinical trial for a vaccine for Lynch syndrome ongoing in the US. That's for healthy people who are Lynch syndrome carriers. And we continue to learn more and more about how to harness the power of our immune system to both prevent and treat cancer. So if you don't know that your tumor is MSI high, you can't take advantage of some of these newer treatment strategies.
I'd like to thank Joan for sharing such a personal story with us today. For more on the MSI testing discussed here today, go to promega.com.
According to recent studies, chronic heartburn affects almost 60 million Americans, and if left untreated and becomes severe, has been linked with esophageal cancer. Unfortunately, most esophageal cancers have a poor prognosis and do not cause symptoms until they've reached an advanced stage when they are harder to treat. As the incidence of esophageal cancer continues to rise, the need for early detection and advancements in screening modalities is paramount.
My name is Dr. William Orsini. I'm 73 years of age. I'm a practicing dermatologist in Monmouth County, New Jersey, and have been so for 42 years. I had intermittent heartburn for probably about 10 years, and I never thought anything of it until I developed a cough that was somewhat debilitating, and in giving lectures and conversing with patients, it was compromising. So in an attempt to find out what the etiology of the cough was, I sought out medical help, and a pulmonologist suggested that the cough was probably not related to my upper respiratory tract, but in fact probably gastrointestinal. And the first endoscopy was basically uninformative, showed just normal esophagitis. The doctor recommended I have an annual surveillance. 2 years subsequent to that, I had another endoscopy, and a week later the diagnosis was confirmed that it was Barrett's esophagus. That was a wake-up call.
One of the most common precancerous conditions of the esophagus, Barrett's esophagus, is thought to be preceded by chronic gastroesophageal reflux disease, or GERD. The American College of Gastroenterology has established screening and surveillance recommendations for high-risk patients. Access Health recently caught up with the director of the esophageal program, gastroenterologist Dr. Michael Smith, to learn more.
About 1 in 10 patients who have chronic uncontrolled reflux disease can develop Barrett's esophagus. Developing Barrett's esophagus is important because those patients are at a much higher risk of developing cancer of the esophagus related to their reflux disease. A patient develops Barrett's esophagus because over time, the acid and bile and other digestive juices and contents of the stomach that are bubbling up into the lower esophagus are irritating the esophagus to the point that the cells inside the esophagus wall change. And it's that change in cell type that generates the risk of cancer. When a patient comes to my office and I'm wondering whether or not there's someone who might develop or have developed Barrett's esophagus and are at risk of developing cancer of the esophagus related to reflux, we have to think about the risk factors that come to mind that put them at higher risk of developing that condition. Those include a history of reflux that's been going on at least 5 years, generally that's been uncontrolled, that they are male, over age 50, Caucasian or white, that they have central obesity, which means that they have obesity around their midline, that they are a current or past smoker, or that they have a family history of either Barrett's esophagus or esophageal adenocarcinoma. While the most common group of people to develop Barrett's esophagus are obese white males, it doesn't mean that everyone who develops Barrett's esophagus is an obese white male. Everyone who has long-standing reflux disease is at risk for developing this condition. The majority of patients who develop Barrett's esophagus have the most benign type, called non-dysplastic Barrett's esophagus. When you look at those cells under the microscope after they've been biopsied, we see normal-looking intestinal cells. They're just in the wrong place in the body. They're from the esophagus. But those cells can acquire changes in how they look, how they interact with the other cells around them. And those changes, which are more advanced, are called dysplasia. So it's important to try and find patients as early as possible and to know that once they've started to develop dysplasia, now's the time to act and try and get rid of those precancerous cells.
And I had 3 ablation treatments at 3-month intervals and subsequently had biopsies, and the biopsies revealed no evidence of Barrett's esophagus. And then I went back every 3 months, 6 months on a yearly basis. 7 years later, the Barrett's returned. I had 2 more ablations, and I go back now on an annual basis, and there's no recurrence of the Barrett's esophagus. Dr. Smith basically saved my life. If one develops esophageal cancer, the prognosis is very grave. I'm indebted to him.
In the last few decades, we've made tremendous strides in our ability to treat patients who have Barrett's esophagus, to get rid of their precancerous cells before they become cancer, and even get rid of early cancers in a life-saving way. The problem is that we still have a lot of work to do a better job of screening our patients who might be at risk of this condition.
In the United States, there are approximately 900,000 high-risk patients a year getting screened for Barrett's esophagus using endoscopy. However, there are no mass screening programs in place for those at risk without the typical symptoms.
What I'm excited about in our field is that recently there are new tools available that allow us to look for those precancerous cells that don't involve endoscopy, that don't involve putting a patient under sedation, that could be done in a doctor's office, that could be done in a laboratory. It only takes about 5 minutes of the patient's time, and when the result comes back, they'll know whether or not they have this precancerous condition and need to go into a surveillance program.
One such test that has been making the rounds is EsoGuard, an esophageal DNA test for Barrett's esophagus and other known precursors to esophageal cancer. Doctors perform a non-invasive, office-based procedure to safely and simply sample cells from the esophagus in order to be sent for analysis. Here's how it works. In most cases, patients swallow a balloon capsule similar in size to a typical daily vitamin tablet. The textured balloon swabs the surface of the distal esophagus to collect the cells used for analysis. Studies have found that it is highly accurate at detecting Barrett's esophagus and other known precursors to esophageal cancer. As with most cancers, the hope for better survival rates lies in early detection and treatment. For more information on our story today, visit EsoGuard.com.
If you missed anything today, you can always visit our website at accesshealth.tv. See you next time.